schools in the UK and several um, advanced in the country. Medical students are expected to have mastered supportive psychotherapy by the time that graduating in Nigeria. The consultant in then many doctors, many consultants in several specialties not tell patients that lost the basic conditions to do things like that because they are going to be the doctors and consultants of the future. So, ladies and gentlemen, I welcome you to our discussion today, an introductory discussion on supportive therapy. Dr. Biola, I think you're taking that.
Okay, yes, sir. Thank you very much, sir, Prof. And thank you, everyone, for being on time. Uh, Today, we'll be looking at some skills for doing basic supportive psychotherapy. In future, we'll go more to do more advanced skills that can be used in application of supportive psychotherapy. By way of introduction, this lecture is going to take us through what is supportive psychotherapy. Then we'll look at theoretical underpinnings of supportive psychotherapy, which will lead us to case formulation in supportive psychotherapy. Then from there, we'll look at the strategies, that's the indications, the strategies, the techniques, a case discussion to see the practicality and the applicability of supportive psychotherapy. By definition, supportive psychotherapy is widely practiced. It is adaptable form of individual therapy aimed at alleviating psychological distress, psychological suffering, with the goal of attaining overall well-being for the individual who have had contact and engagement with supportive psychotherapy. The focus of supportive can be looked at. The main primary focus is to help the patient navigate and improve their extra psychic world suffering and to enhance their overall functioning and quality of life within the patient or the client's social and cultural environment. We'll come to make a distinction between what is extra psychic and extra psychic briefly, shortly. And the other focus of supportive psychotherapy is to see what can be changed in in the present to improve the patient's immediate well-being through strengthening coping mechanisms, enhancing self-esteem, and fostering resilience in the face of life's challenges. It is applicable for individuals who may not be suited for or able to tolerate more intensive insight-oriented therapies. And this is those insight-oriented therapies are usually reserved from the intrapsychic psychotherapy, while that is intrapsychic suffering, while supportive therapy is reserved or usually applicable for extrapsychic suffering. The key difference between intrapsychic and extrapsychic phenomena is that the intrapsychic will refer to the within the person's mind, while the extrapsychic refer to what is happening outside the individual, but still the person's mind. So it's looking at more in-depth issues of the person's mind. That is in strategic, where it's looking at the surface level issues of the person's mind. So the focus is on the internal world of the person in terms of the thought, the feeling, the fantasies, the memories, all those things that we refer to as the unconscious process. And while the intrapsychic is looking at issues that have to do with relationship, the social environment, the life circumstances, life stress, lifestyle issues, and practical realities and problems that will need practical solutions. So that's the extra psychic focus. The goal in intrapsychic approach is to see that to improve the insight to help in resolution of underlying conflict, which may be from, depending on the theoretical underlying, it may be from childhood trauma or some unresolved conflict. While the extrapsychic is looking at how to relieve symptoms now and then. And this will entails things like to improve the coping of the individual, to increase the adaptability of the individual, so that all this will help to relieve the person's symptoms and help the person to cope well. And some of those things that usually take place, or that usually do, may include things like communication, improving communication skills, teaching the person how to resolve conflict, how to solve problem, setting boundary, assessing community resources. The technique typically used in the intrapsychic uh, to use interpretation free association, which are depth with psychodynamic therapy. Whether in the extrapsychic, things like advice, reassurance, skill building are emphasized there. And while the intrapsychic usually look more into the past, from where the primary development of supportive psychotherapy comes from, which is the psychoanalysis, the extrapsychic, which is the supportive psychotherapy, is trying to deal with, look at the present challenges and how to help the individual resolve those present challenges so that the individual can adapt well and be able to function effectively in the present. The therapist's role include observation and interpretation of what is happening in the extrapsychic aspect, while the therapist play the role of an active guide and the supporter for the individual or the client or the patient that is going through supportive psychotherapy. So this briefly is just to tell us that while the intrapsychic challenges are usually addressed or faced with the in-depth therapies, the extrapsychic issues are usually the focus of supportive psychotherapy. Despite that supportive psychotherapy is looking at extrapsychic sufferings symptoms in that realm, is also not just based just like that, that is just my wishful thinking to just bring anything anyhow approach to solve this problem. It's also founded and rooted in a already existing theory that we know that help to guide focused what psychotherapy is about. And that is looking at it from the psychoanalytic, cognitive behavioral, learning theory, humanistic or person centered therapy theory, existential therapy, narrative therapy, systemic theory, positive psychology, and mindfulness based integration into most of the psychotherapy that we have. So these theories usually fuel what is borrowed in the ability to be able to carry out supportive staff so that they can help to resolve those surface superficial level issues that individuals do go through or experience in uh, in their day-to-day interaction so that supportive support can help to relieve that. For instance, in the psychoanalysis, why the core principle is about ego psychology. There are many other people who are the new Freudians. They brought about more other issues like object relations, self psychology, the jungle psychology, and interpersonal relationship, interpersonal psychology, attachment relation issues. So all these were looked at from the psychodynamic perspective. But despite that, they are developed from that psychodynamic angle. Some of the elements have been borrowed, and that is applied in supportive psychotherapy in order to be able to strengthen coping mechanism, to be able to explore relationship issues, and to be able to foster empathy and self-awareness by understanding transference and counter-transference. In the cognitive behavioral domain, where we can identify and modify maladaptive thought pattern, these are also borrowed in supportive psychotherapy to promote healthier coping strategies and behavioral change. Why in cognitive behavioral therapy, we might be talking of things like cognitive restructuring. But in supportive therapy, we're talking about thought reframing, cognitive reframing, which is not in-depth like cognitive restructuring, but it's one of those things that we can do to help the individual to know I can make some affirmation that can be helpful and I can go and use it to help me resolve those conflicts that is going so that the individual can cope better. There are many contributions to learning theory, but some of the base main paradigm there is about conditioning and reinforcement, from the classical conditioning to operant conditioning and the various principles that operate there. So all those are there that guides the degree or the ratio and the interval or reinforcement that help about forming the formation of bad habits, and that can also help in rewinding or changing that habit or suffering that the individual might be going through. So that is also borrowed in supportive psychotherapy, to be able to understand and change learned responses to stimuli that individual go through. So what this is telling us in essence is that for somebody to be effective in carrying out supportive psychotherapy, he needs to also be able to understand these theories. So what I'm giving here are just the periphery of what is those theories are about. Humanistic, the person-centered approach, usually talks about empathy. They emphasize empathy more, unconditional positive regard, and genuineness. And this is one of those paradigms that lie in our assessment process, in gaining rapport, in keeping the individual engaged through the session, and be able to give the individual that, well, whatever is operating is non-judgmental approach, the humanistic and the person-centered approach able to empower it. The existential therapy operates to be able to help us address freedom, choices, meaning, mortality, because it's help us to be able to find philosophical understanding of what it is about mortality and the anxiety that we know we are not immortal that it brought with it, and what how we can be able to address those. So those deep depth questions of living, of life, the existential therapy approach that, while some of those elements are also borrowed in trying to help the and applied in positive psychotherapy. Another essential aspect of it is the okay. Another essential aspect of it is the narrative therapy. The stories we tell. I will tell those stories. I will present those stories. They'll be able to either continue to perpetuate our problems and or otherwise. And it is through this mechanism, which is one of those, the intersubjective space, that is the tool we use to be able to explore that to be able to bring issues to that intersubjective space, is through narration. So that narration is also employed and exploited in supportive psychotherapy, to be able to empower the patient so that they can reframe the story they are talking about, and those reconstruction will help their personal narratives to start adapting more effective and functioning living. There's also the system theory that look at the relationship of individual, from individual to social systems, and how this take place is in the system theory, where we look at individual is not an island. There are people that surround the individual, and the functioning of how the individual play in that system, those that enable or did not enable the individual from getting sick, and the role they play. The system theory try to look at that. The system theory try to look at that, and this is also borrowed in order to that, and is being used to improve relational dynamics and understand the systemic influence on behavior of the patient or the client that were offering supportive psychotherapy. One of the latest field in psychology is positive psychology, and we also have positive psychiatry, and this is about talking about strengths and virtues. From positive psychology, we have come to learn that there are six broad virtues, which include things like wisdom, our transcendence, our humanity. These are some of the virtues there, and each virtue have strength that lies under it. Like in the transcendence, there are virtues that lies there, like the issue of spirituality lies there. In humanity, there are virtues there are strengths that like as a virtue in humanity that have to do with love. So the positive psychology help us to be able to identify strengths, the character strengths that individual may have, and they can be helped and improved in that individual. So in essence, it's trying to look at to help the individual from their already existing point of strength, so that we can amplify those strengths they have And by amplifying those strengths, that will help them to function well. And supportive psychotherapy also embrace that. And by so doing, it will not only help the individual to build resilience, but also at the long run to foster and flourish. Also, mindfulness plays its own role in this process. And mindfulness help to enhance the present moment awareness and acceptance. And this is a skill that helps us to be able to identify what is going on in our mind. It's not about dulling the mind. No, it's about to even be able to be aware. If I'm feeling pain, am I aware of that pain that I'm feeling? Or I'm trying to just numb it, and because I'm trying to numb it, I'm not be able to I'll be aware of it, to be able to understand it. And because if you cannot understand the intensity of that pain, it might be difficult for us to be able to appreciate when what we are doing is helping to that is reducing the pain or otherwise. And mindfulness based approach is helping us to look at it, to be able to be aware of that, so that we can accept it and look for how to regulate it subsequently, so that we can reduce that through so many techniques like mindfulness based practices to reduce stress. So all those are integrated to be part and parcel of some of the theoretical underpinnings that supporting psychotherapy lean up. As a therapy on its own, it doesn't have its own unique theory, but it borrows from all these theories in order to be able to do that. And that is why being aware of them is very essential. And the approach is to the integration. For somebody who want to carry out supportive therapy, it should be able to integrate one or two of these together, one more than one of these together, so that you'll be able to tailor it to meet the treatment, to enhance emotional support, improve functioning, and foster personal growth. And those theories are not there for the fun of it. Those theories should be able to help us to be able to formulate, because without having those theories, it will be difficult for us to be able to understand what the patient's problem is, how does the problem come about, and why is it causing suffering in the patient now, and what can we do to be able to address that suffering that is happening now. And that is why case formulation is very important. And this approach is one of the big models, the common models that we can use. There are many models to case formulation, but the 5 pill model is the common model, where it helps us to identify what are the presenting issues that the person come with. Like I have a loss, I didn't pass my exam, or there was an accident that occurred, things like that, that may lead to a major diagnosis that individual might have, maybe anxiety, depression, substance use. But there will be those issues that the individual will come to complain. I've tried to stop smoking, but I find it difficult. So those presenting issues are there. Then we also try to identify what are the predisposing factor to the individual, which are long-term factors that have enable the individual to become more vulnerable to those health, to be able to succumb and develop those health problems. So that may be genetic, or it might be epigenetic in nature, or it might be related to our environment of rearing and upbringing, where childhood trauma can have effect and impact now. And there can be so many other manipulation in the environment, where that's why the environment have its own reciprocal inhibition or reciprocal approach to hinder our well-being or otherwise. There we also have precipitating factor, which are things that immediately triggers and leads to the crisis. And this can come in several losses, in several major life events, because when they occur often at times they occur suddenly. And because they are so sudden and huge, they drain us of our resources for coping, and usually that make us to succumb. Then we also have those the fourth P, which is the perpetuating factor. Those things that keep the issues ongoing and continue to sustain it, continue to worsen it. And this may have to do with our maladaptive coping mechanism, which either the psychodynamic might identify from long time ago, or the cognitive behavioral therapy might be able to identify the maladaptive coping mechanism. And so all the system theory might be able to identify the isolationism that the individual is experiencing, or the loneliness the individual is experiencing, because of the kind of family type, the kind of social network the individual is entangled with. So these are very important, because the presence of those things usually might mark or promote the individual to get well or from getting well. protective factors are there, and it is the availability, their present, that continue to strengthen and provide the resources that help the persons to cope. And these are usually by identifying those supportive relationship, the resilience the individual have, and like I've talked about positive psychology before, which look at issues from strength-based approach. So by looking at those character strengths the individual have and enhancing those character strengths, it will help this individual to cope, and we can exploit it. Some of the protective mechanism can be having supportive family member, having resources to provide for the treatment that the individual needs, or having functional people in the individual that can provide the resources if the individual doesn't have or might have lost it because of the illness the individual is going through. So what this portends to us is that it requires the therapist to have a good understanding of the patient or the client history and the current living conditions. And now I want to see how we can briefly apply these 5 P's to integrate it to understand from the theoretical underpinnings. And for instance, the presenting issues, if you want to look at it from a psychoanalytic approach, which is where the case formulation come from, is to be able to identify how explore how current symptoms may be linked to the past events, to past relationship, to past unconscious conflict, to be able to identify those long-lived defense maladaptive mechanisms that the individual have in the individual. So that's how the present issues will be understood and looked at from a psychoanalytic approach. Whereas from the cognitive approach, it will try to identify how this is operating in the thought of the individual, looking at the automatic negative thought, the core issues that are there that we can move from the automatic negative thought, move through the schemas to get to the depth issues so that we can be able to find what is amenable to be changed and be used to help the individual to get to it. So these are the way the present issue be looked at from the those theoretical framework. And the same thing, if you look at it from the humanistic or person centered approach, they want to focus on the patient's correct experience and their self perception in a non-judgmental way so that the individual will be able to open up, tell it the way it is, so that that way it will help us to be able to understand that and be able to see how that can be used to every individual to cope. So this has been provided to show that the 5 P's are existing, but they are not existing in a vacuum. They are going to be utilized based on the theoretical approach, and that will help to be able to understand the presenting issues, the predisposing factors, the perpetuating factors, the precipitating factors, and the protection, the strength that the individual may have that are able to foster the individual to get well. So these have been provided, and since the slides will be shared, I'm sure we'll be able to find time and be able to digest this better. So we'll come now to the other goals, I mean, the focus of this session, which is what is the goal of supportive psychotherapy? There's an overall goal, and there's also in crisis situation what the goal will be like. The overall goal of support is to ameliorate symptoms so that we can reduce the severity and frequency of distressing symptoms. The second goal is to improve adaptation so that we can enhance the patient's ability to cope, so that we can enhance the patient ability to cope effectively, and so that that way the patient will be able to face life challenges and function effectively in their environment. Another overall goal is to enhance the self-esteem of the individual, where the individual can have a positive self-regard, learn the value of showing self-kindness, not narcissism to the self, so that they can have a better sense of self-worth that will help to challenge those negative self-esteem that can promote and lead to developing those ruminative thoughts that might generate uh, the maladaptive thinking pattern that will ultimately might lead to depressive situations. So these are what the focus is like, so that they can be able to enhance self-esteem and also to improve the functioning of the individual, so that the individual, apart from having the quality of life, so the individual can play his role and be an engaging member of the community in more many meaningful way in their personal life, in their social life, in their religious life, in their occupational life, and all other aspects of life that the individual will, so that the individual can function effectively and be able to effectively play his own role there. Then, when it comes to crisis, the goal of supportive psychology is to be able to restore the homeostatic balance that the individual that has been shattered or disturbed by the stressor that is there. So, and this may include diminishing the vulnerability factor of the individual, and that way the individual will be able to cope to face the crisis. And in crisis, we also support is used to mobilize the strength, the character strength of the individual, so that their abilities can be mobilized and gets also the supportive, the resources they have in the community that exist, a part of their social uh, capital, can be utilized so that they can be able to effectively function. And through that way, we will now promote adaptive coping mechanism by identifying that maybe the defense mechanisms are on LD ones. Can we look for LD ones and help promote that in them, so that that will help them to function while they are struggling to learn the more others form of therapy or depth one to change the maladaptive one. And part of it when it comes to crisis to focus on solving the immediate problem so that the individual can exist well. So the general indications for supportive psychotherapy, this gave us what the psychotherapy continuum looks like when we look at from the basically from the psychopathology, psychological structure continuum, or from when we look at it more from the psychodynamic view. The psychodynamics believe that when there are extra psychic challenges, that is where the individual is the most impaired, supportive psychotherapy is the most appropriate, which to my own screen will be the left of me as I'm speaking to you. But when it's looked at the uh, from when the individual is least impaired, that the individual is having more depth issues, not having more obvious challenges that will be there. But those depth issues are there and they are still handicapping for the individual, and then expressive, which is where this the psychodynamic therapy actually comes into play, whether it's the classical psychoanalysis or the other forms that may come. That's where they play. And in between, we have a mixture of it, where people are moderately impaired, they're supportive, expressive, and when they're going to the leadership, they become expressive, supportive. So it goes in that way. So which means the level of support we give will be based on the level of impairment. The more impaired the individual will, then the likelihood and better that supportive psychotherapy should be applied. And the less impaired the individual looks to be, then the other form of therapy will play a role and will help the individual to be able to deal with those depth issues, those core, rigid, faulty thinking, those depth maladaptive coping mechanisms. You'll be able to deal with it and be able to change it. So now I've just given us just like a broad overview of the indications, but these are specific indications that is there that in situation of high impairment, then supportive psychotherapy is indicated because it will help to improve the ego functions, coping, and self-esteem. In acute distress, supportive psychotherapy will take place. When somebody lose their job, their relationship break up, they need supportive psychotherapy to be able to deal with that acute situation so that they will not succumb and break down completely. In medical illnesses, supportive psychotherapy is also indicated because it helps to provide the needed psychological support that they need by linking them with their resources, their source of support, their functional support system, so that the individual can get the needed help and be able to recuperate. And when they are lost, grief is associated. Supportive psychotherapy is also indicated, and the situation for addiction. That means, in essence, it addresses the immediate needs and promotes stability. So, any situation that we find that there's an immediate need for the patient and we need to quickly stabilize, supportive psychotherapy is needed. And that is why it's one of those therapy that is expected for any psychotherapist to be able, if at least in the basic form. You might learn other forms in depth, but in the basic form, supportive psychotherapy should be known and practiced. What are the contraindications for supportive psychotherapy? That usually few. Generally, they look at it that it's only when psychotherapy itself is contraindicated, like in the case of delirium, drug intoxication, late stage dementia, and malingering because they are feigning the illness or unconsciously failing the illness. though some people might say it's conscious, but at times it might be unconscious. And the other situation that we also look at it is that when the patient seeking deep personality level change, the supportive psychotherapy would not be appropriate then, because this individual need more depth psychotherapy to be able to help them to deal with those depth level personality issues. And in the case of actively psychotic or severely impaired, then there may be no room, opportunity to engage, to be able to create that intersubjectivity space to allow the supportive psychotherapy to take place. And so that may be challenging too. But also, we should be able to know that it will be inappropriate to deprive a patient who may benefit from a more depth psychotherapy, because we felt that okay, I only know supportive psychotherapy, I will keep offering this patient. Like I've said, supportive psychotherapy will deal more with surface level issues, but the intrapsychic challenges, supportive psych will not be able to deal with that. And that is why knowing this is good. It contributes a large chunk of most of the other depth psychotherapy, but we should not deny patient that needs those depth psychotherapy. So we should be able to understand the limits of supportive psychotherapy and be able to refer as the patient continues to respond, because they will need more in order to be able to fully function and not to continue to reduce their resilience by not offering them the more services, the more help they needed. By not offering for them, we'll be reducing their resilience, and that will continue to was also make them to be more vulnerable, and the rate of relapse and the occurrence of their challenges might be high. So, having looked at the indications, what are the strategies and techniques that supportive psychotherapy use to be able to achieve healing for the individual? Broadly, supportive psychotherapy use a lot of techniques to engage and guide patients, and the purpose is to strengthen coping mechanism, reduce symptoms, and improve survival. Effective implementation requires strong therapeutic alliance and a solid understanding of the patient's psychodynamics. Uh, the strategies specifically now is that supportive psychotherapy provide a structured framework for guiding therapeutic intervention, and that is what the strategy is being used. And one of the things it does is to strengthen defenses. The other thing is to maintain and repair therapeutic relationships. The third is to promote self-esteem. The fourth is the therapeutic self-disclosure. It will manage and be able to be adaptable or intervene using those therapeutic theoretical models or approaches that I've mentioned, and to be able to work in the present. So those are the strategies that supportive psychotherapy use. So that we don't understand this, then our strategies to help will be weakening. Even if we are applying the technique without these strategies, they will not be able to effectively use that technique to help the people. Because if you apply a technique and it's not promoting defenses, that's strengthening healthy defenses, then there'll be problem. It's not helping to repair the relationship in the therapeutic situation, then there will be problem, because we need to build alliance. It's not helping to promote self-esteem in the patient, then there will be problem. That we have those, you are giving advice that is not promoting self-esteem. You are giving other techniques that will be used, like uh, giving advice, what they call normalization techniques. So all those things that are being used without applying them, if you don't have these strategies to apply them, then the technique might not be effective and will not do what we expect it to do in order to provide for what is needed for the patient to be effective and be able to recuperate back to benefit from that therapeutic encounter. What are the therapeutic interventions supportive psychotherapy? I've tried to list this, and please, I will also endorse to please pay attention to them, because this will help us to get an approach to be able to at least use supportive psychotherapy at the basic level. One of the approaches is the conversational style, because supportive psychotherapy use relaxed conversational approach to build rapport and facilitate communication. So, which means the empathy that have been overemphasized will continue to play a role here. And so, the way we talk, the way we approach, our way of not being domineering, our way of not being passively aggressive when we talk, our way of not being aggressive with our talk, our way of being assertive. Assertive is the empathic talk that take place. It's not by being aggressive that no, you must shout your way. That's where you get what you want, or being passively aggressive that even though it's only what you want to hear that you are only promoting, you are not interested to listen to allow the conversation to flow. But with the assertive way, that will be that okay, even though this is what it will be, you allow it to take place. You allow that conversation to take place without necessarily being aggressive on the individual, on the person that the conversation is to, so that we don't shout them down. We don't let our gesticulation, our non-verbal communication cues show to the individual that we don't believe what the person is saying, we don't trust what the person is. So that conversation is very effective, is very essential, or otherwise it's going to affect the therapeutic alliance. Another therapeutic intervention being done is to use praise. We use praise, we use reassurance, we use encouragement. This work in order to be able to help the individual to be able to understand that I'm being listened to, is getting feedback for what is being said, and is being assured that things is going to be improved, and it's going to help the individual to now see that oh, somebody really care and is listening to me. It will enhance the self-esteem, and it also promote the motivation of the individual, and that's the encouragement to give the individual to get well, to be able to do that needful, what has been agreed upon, to be able to practice it so that the individual can get well. The praise is there. Then we also give advice. Advice is should be practical guidance. Should be based on those theoretical underpinning that I've talked about. Should not be based on I just believe that this is what comes to mind. No, it should be based on those theoretical underpinning. Because if they are not based on that, we are going to misgive a maladaptive advice, or might give advice that can have a fatal outcome. So we should be able to let those theoretical underpinning guide the advice we give, and so that will be helpful to see that the individual will be able to function effectively. And another thing with advice that will help to generate it together with the client, so that they can be able to pick the most adaptive and prioritize that to utilize to solve the problem. Rationalization or reframing is one of those things that take place, and this is a knowledge depth way that is similar to cognitive restructuring, but it's not cognitive restructuring. So this is just to help the individual to be able to reframe their negative thought and belief into a more adaptive way, but it's not doing cognitive restructuring in the in-depth way that is being approached and that is being processed and utilized in cognitive therapy. uh, Other techniques that after doing all this, then rehearsal take place. Then we provide guidance, and to because it's called anticipatory, because you want the individual to be able to rehearse it in the session, to be able to practice it, so that it can be effective when it will be needed as the individual leave the session, so that those future that will come, immediate future and long, it can be effective. So those things will be rehearsed, the problem solving skills, the coping strategy will be rehearsed, and guidance will be provided on how to use them in session. Then we also have empathic confrontation, clarification, and interpretation. And these are some of those things that we use to be able to challenge maladaptive behavior that people might have, and to be able to use to clarify distorted perception. We may have clients that may have problem with substance use. And those that have it, then when they come, empathic confrontation will help them to be able to see that you are not judging them, but you are helping them, and from a point of positive self-regard, to be able to open so that they can open up, and that way we help the engagement to take place. So that if you are doing brief intervention or motivational interviewing or motivational enhancement interviewing and those other things, now it will help them to be able to engage with it and effectively benefit from it. So the supportive talent play a role there. And lastly, from this, it helps in the processing, the elaboration, the generation, the interleaving, and the critical reflection that take place. The interleaving usually look at the interconnectedness of how we look at one thing, and we can alternate to see that they are there in equal proportion, so that we can finish an issue, move to the next, then we'll alternate like so that, but we don't leave, and we can leave one issue, for future. This helps us to plan it effectively. And when all these are done right, it helps to facilitate deeper understanding and the integration of new information will be helpful, and the patient can use it and be amenable to the application of it to their advantage and be able to be effective and function well. But an acronym is created so that we can be able to apply these basic supportive psychotherapeutic techniques. And the acronym is called C partner. The C is referring to conversational style, which I've talked about earlier on, if you the former slide. The P, try to look at the praise, the assurance, and the encouragement. All these have to do with the feedback and the motivation. That the A, the advice, the I, the rationalizing and the reframing that take place there. The T is talking about the rehearsal, we have to train them, because the rehearsal is about the training that the therapist will provide, and we practice in session so that the patient can utilize, and that is the T. The N is to navigate with empathic confrontation, clarification, and interpretation. The E is to provide more elaboration and processing for deeper understanding. And the R for reflection, so that the individual can be able to have a better contemplation of what is going on and be able to integrate those things to improve their life and well-being in the process. So this is the acronym. Understand this acronym we should make it easier for us to start applying these techniques in our therapeutic encounters with patients. In practice, to use the C partner is to mean that this question guidelines will help us to do that. Whatever we do, we should start with a conversational style to build rapport, the C. Then we should be able to offer praise and encouragement throughout the session. You should be able to provide advice when appropriate. Often people will say, don't give unsolicited advice, which works well with supportive psychotherapy. Make sure that it is indicated, because that may help it to be effective for the patient. Then we help rationalization and reframe negative thought. We train the clients through rehearsal of coping strategies so that they can utilize it well. Then we help them to navigate challenges using empathic confrontation and clarification. Then we encourage elaboration and processing of new insight, and we promote reflection and integration of sessions content. So these questions or these statements, we in essence will help us to be able to use them in practice. So that when you are doing supportive psychotherapy, you should be asking yourself, am I using a conversational style? Am I using praise the appropriate way? Am I giving encouragement where it is needed in the session, and where it is need where I should do it? And that is very essential. And am I providing the right advice, the evidence supported advice based on those theoretical underpinnings that is there? Am I be able to help to rationalize, to provide a rationale for what it is, and so that the individual can be able to think and flow with me, so that I can be able to appreciate that, okay, when we say let's change what this is, then it can stick with the individual. I'll be able to know the reframing will help with the negative self-talk or the negative process that is going on. Then training in the session. Okay, when you are there, this is the way to be assertive. This is the way to speak assertively. This is the way to dress. This is the way to talk assertive. To behave assertively. This way you'll be behaving the aggressive way, and might have been what is bringing them. So let's role play. Role play will help to be able to do this. So this, and if the patient cannot get it, then we can also do some other people to role play, or we can switch roles where the patient will now be the therapist and you will now try to be the patient. And try that way, try to practice what you're trying to give, so that the individual will be trained through that way and be able to understand what it means, and to be able to use effective coping strategies. And that way, we continue to help them that whenever there are issues we need to clarify, then we help them navigate through it using empathic confrontation. And after doing all this, we continue to encourage them. We continue to summarize and elaborate on this to see that the people can be able to understand that, okay, what is being done is for me to have a better understanding or gain new understanding of what the problem is. This is why the problem, this how to deal with the problem, and be able to and to promote reflection to promote contemplation so that the individual can integrate all this. So when we are able to use this statement to guide us, our C partner will be effective and be very uh, practical to use. But to illustrate so that it can give us what I've been trying to talk about is to talk about that this is a practice case and is to talk about Mr. A's journey through supportive psychotherapy. Mr. A is a 28-year-old Nigerian man working as a junior manager in a bank in Nigeria. He recently lost his father to a sudden illness and is struggling with grief, work related stress, and feelings of inadequacy. He's experiencing difficulty sleeping, loss of appetite, and withdrawal from social activities. Mr. A decides to seek therapy after his performance at work begins to suffer. So, this is Mr. A's dilemma. To start with, is like I've said, that we have to create a case formulation. So for Mr. A, the presenting issues based on the case are difficulty sleeping, loss of appetite, social withdrawal, grief, work stress, low self-esteem. This is what Mr. A will tell us, and we take note of that. And how will we be able to use the C to see that our conversational style and understanding is we use the humanistic or the person-centered approach where we interact, we engage with the person in a non-judgmental way. So this help to achieve this. Then when we look at predisposing factors, we keep looking what are the cultural expectations of Mr. A. Are there issues that have to do with relationships there in Mr. A, both at home if he's married or at work and other social role that is playing the relationship that survive there and the feel of inadequacy that are there, what is happening and what are these have to do with the Mr. A relationship with his father from long time ago. The psychoanalytic approach help us to be able to understand it and help us to go back to those childhood issues so that we can be able to understand, oh, this is why Mr. A is not able to grieve the appropriate way that we expected, that is coming now with pathological grief. Then precipitating factors, we look at the sudden loss and the work related are issues. They are major life events. For Mr. A, the sudden loss of the is a major life event. Work-related stressor is chronic for Mr. A, which are like the daily assaults that we experience. And this is there, these two are precipitating why Mr. A is sick and presenting to us as at now. And one of the way we can understand that is through cognitive behavioral approach that we know when the sudden loss occur. What does it mean to the individual? How does it bring negative self-talk to the individual? How does it shatter the ego of the person? And how does it shatter the self-esteem of the individual? And how does that affect the performance of the individual at work? And how do the thoughts that keep coming from that work-related stress that I'm an inadequate, I could not fulfill my job obligation. Everybody is challenging me that I'm not living up to expectation. So all this keep coming and all this are there. So cognitive behavioral approach will help us to look at that. One precipitating factor. The perpetuating factor that keeps it going. The Mr. A continue to withdraw from others. Then he doesn't want to grieve. But grief is part of the normal process. And by now engaging with it to do the adaptive grieving. Now, the delayed grieving is affecting and is coming. And the negative self-talk that take place, the work stress, cognitive behavioral approach will help us to be able to understand it. And the protective factors, where we want to look how resilient Mr. A has been before his father died, his willingness to keep working despite losing his father, the potential social support that you have, the cultural strength. Positive psychology is helping us to try to elevate the character strength of Mr. A. And all this will now be integrated to help Mr. A when it comes when we engage in with this case formulation, we're able to understand issues that needs attention of the supportive psychotherapy techniques to be intervened upon. So, and this is just to provide for us what it look like that when Mr. A comes, what takes place in session, the focus of it, how we apply the C partner, and what supporting psychotherapy usually or typically might take place there. And when we look at it, the first session is to do initial assessment and rapport, and that will be able to get our presenting issues that Mr. A come with. And our conversational style is very important. The praise for seeking help, that yes, we are trying to normalize for Mr. A, that look, what happened to you? It's normal. All of us ask for help, whether we like it or not. An example that usually comes to mind is our politicians are very powerful. But when it comes to election, even if there will be rigging, which we don't know, even if there will be rigging, they still come and campaign. They still beg us for their vote. So there are people who seek for help. They don't say because I have all that it takes, they will not do the needful for them to get the vote. So they still ask for it. So they beg for it. So this is normal thing they do. You are not begging for it, but you for seeking for help is part of strength. So we praise that. Then we advise on self-care from Mr. A. Okay, you should have adequate sleep. You should eat effectively. Oh, I lost a pattern. Yes, but you need to eat what is needed in order to provide the energy that is effective for you. And now we can help to say that, oh, you don't feel bad about those. Are you still not meeting up the requirement at all? You are mean that means you are not doing bad. So why this guilt feeling that you're having? So all these are there, and the support that will help to maintain the therapeutic relation. It will promote self-esteem and working in the present. It helps to this. The next session the Mr. A will come to will to explore the grief and the work stress, and that we will use the other parts of the C partner where we train in deep breathing in order for the Mr. A to be able to learn how to deal with stress and manage in the now and then, so that whenever he's stressed up, this is something you can do to relax. Then we help them to navigate the grief process so that the Mr. A can understand that our mortality is part of living, and how we celebrate the dead might be culturally appropriate and might not be culturally appropriate. So by understanding that, we can be able to help Mr. A to navigate the grief process, and we can elaborate on the father patient relationship, looking at their past and looking at the psychodynamic issues that have taken place. So that will help us to understand what is taking place. And from that way, we can identify some of the maladaptive, unhealthy defense mechanisms that are there. And we can look at some adaptive that Mr. A might have, and we can look for that to promote well being for Mr. A. And that way, we come to E, the R, by reflecting on grief, stress connection. So that helps Mr. A to understand that is because I'm trying not to grieve the right way. This is affecting me. I really need to create time to grieve, to understand, so that this can help me to be more healthy, to be able to engage and get back. So that may be the second session, an issue that will take place there. The third session we continue from the first two sessions, where they will be reviewed, and then we'll start building coping strategies for Mr. A. And this will entail using part of the C partner, where our conversational style will help us to do check-in, which we usually do in every therapeutic encounter, to see what is there, any improvement, what are the challenges, this person was able to practice what we do in session, out of session, all those will take place. Then praise for practice exercise take place, advice on work communication take place, and reframing seeking support as strength. All these are there, and we're able that way to build the coping strategy for Mr. A. So that help Mr. A to be effective on that. There are many other sessions that will take place, but based on the need of Mr. A, all this until we get to termination, the last session. And the termination will come consolidation, where we can still use all the parts of the C partner, where all of them will be effective. And this will help to promote defenses, we help to maintain therapy, we help to promote self-esteem, work in the present and therapy. And its termination, which is usually the last session, we have to reflect on what have taken place, the improvement that have been achieved, and what Mr. A is expected to keep doing in order to keep consolidating on the gains that will be there, and what might be needed, or if the individual need more referral, that's still on some unresolved issue that the supporters cannot take care of. Like I've said, part of the indication and contraindication for something, we should not deny people that may need more depth psychotherapy just because we feel we can provide supportive psychotherapy for them. So all this take place so that we can handle, and relapse prevention is also working to it. And that way we're able to help Mr. A. I hope that this will help to illustrate for us the practicality in a very simple way of doing basic supportive psychotherapy. In summary, supportive psychotherapy is a valuable and effective treatment approach for a wide range of patients and conditions. By understanding and integrating the case formulation, the core principles, the strategic goals and techniques, the therapist can provide meaningful support and promote positive outcome. we should remember we need ongoing training to effectively do supportive psychotherapy. We need supervision to effectively supportive psychotherapy. We must also be ethical. I want to believe all of us that are here in this session have done one ethic course or the other. So we must not forget our ethical practice, which are essential for effective use of supportive psychotherapy. My final thought is to let us know that supportive psychotherapy is not just about providing support, it's about empowering patients, our clients, to build resilience, to manage their symptoms, and to live more meaningful life. Thank you very much. Where we go to the question and answer. Thank you.
Thank you very much, Tajudeen, for a beautiful presentation.
Thank you, sir.
I'm sure that even if it is perfectly done, the issues, the questions, the thoughts, and we have the next several minutes to deal with those things. How many of us are here? About 20, some 23 of them when I checked last. So let's give it a thought. What are there? Are there any comments? Are there any issues that we want to raise? We're having the next several minutes to raise these issues and discuss among ourselves. And even when we stop at noon, it's not going to be the end of the discussion. The discussion will continue in the chat group. And maybe after we finish the discussion, some few announcements will be made because it's not just okay to come and sit down and listen to lectures. We need to see how well we are following and getting at it. I'm not exactly saying an exam, but there should be some level of seeing how individuals are doing. And like I probably mentioned last time, at the end of this series of general lectures, we will start in-depth discussion and teaching in each of them. So for today, thank you, Dr. Abiola, again. I'm sure some people have sent some clapping hands and stuff. I'm sure Abiola is probably for one or two of them. But the point now is, are there any questions, are there any comments, are there any explanations that you further need? So we have the next several minutes open to this. You have option of either typing what your questions or issues are, or you unmute yourself and ask your question verbally. So we have some minutes to do that now. Are there any questions written down? Does anybody have a question he wants to ask? Because,
No,
some
no
people,
question yet on the chat, but no question yet on the chat. So, thank you, sir.
yeah. Well, the Mandela, you did a good job. You highlighted things in a very straightforward way. And so if nobody is asking a question, it is justified. So thank you again for that. But the question I have is in you mentioned genetic, epigenetic thing. I don't know. Okay, someone would like to speak. Please unmute yourself and ask your question. I just saw someone want to speak. Can you unmute yourself and ask or make your comment, please?
Okay. Thank you, Prof. Sir. Let me commend Dr. Abiola for that very brilliant presentations on a very, very important topic, supportive psychotherapy. My name is Olaito Sali. So, and I'm delighted to be part of the participant at today's meeting. I remember as a resident when we were going for exams, when we were trying to read a topic related to psychotherapy generally, you would hear from our seniors said, even if you cannot remember anything, just remember to say supportive psychotherapy, you will not be wrong. And with the explanations the in-depth of the discussion on supportive psychotherapy that Dr. Abiola has provided today. So it showed clearly why this psychotherapy is much more relevant, particularly in our own environments, and when we compare to other claims, and why it has applications in a varying range of conditions as it relates to both in mental health as well as physical illness as well. So again, it also, at least it was able to underscore the need why it's also employ other psychotherapeutic technique. Even while we're talking about psychotherapy, I've heard different form of psychotherapy modality in terms of is the same technique that also make use of both the psychodynamic, psychoanalytic within the same process. Cognitive behavioral therapy comes in, humanistic comes in all, even though there are a bit of it, but you need applicability of all this for you to be able to do effective supportive psychotherapy. My questions will in terms of look at the CBT, when we want to talk about CBT, we talk about CBT being structure. We also talk about it in the name of the required minimum sessions that we need to have. Then you ask in some literature, we say 12 to 15 sessions and all that. So I want to ask for supportive psychotherapy, is there evidence of that also for us to say, okay, even though patients present with varying range of symptoms and they have different life events, other social contributing factors and all that, but are there research that have also shown, regardless of the patient or the clients you are dealing with, as long as you are providing a supportive psychotherapy, are there minimum sessions one needs to have for it to be effective? Again, I want to thank you once again, sir, for that brilliant presentation. Thank you for the opportunity, Professor. Over, sir.
Okay, thank you very much, Dr. Solium. Uh, this is a very effective and good question, and it's one of those things that uh, people do ask. The supportive psychotherapy, what is it structured like other this thing? And you have answered the question that yes, it's structured. The other thing that people might ask is uh, how many sessions is needed. Of course, it's like every other form of therapy, and that's what we call brief therapy. They are not ultra brief therapy. So it's expected that you should be able to have at least 6 sections of supportive psychotherapy. And it may go as high as 20, 40, still being part of brief support psychotherapy. So, um, so it obeys those rules for every brief psychotherapy. If it's less than 6, we may talk that maybe they're ultra brief, but no. So for this reason that supportive psychotherapy is very uh, essential and versatile to be used in the sense that it's one of those therapy that can be applied in most of the situations that will exist, and it's one of those therapy that in our environment that might be easier to quickly grasp some level of expertise in it and use it more. Yes, we use some part of it, but we don't use it in a structured way in most of our encounter. But this is pointing that yes, should be able to use it in a structured way, and that is why if you look at the C parts that I gave as a guide and the Mr. A's case that I gave, and you can see I just listed it that to the terminal. I didn't try to specify that Mr. A gets 6 sessions or 12 sessions because all this will be individualized for the patient. And a typical psychotherapy session should be about 45 minutes average, and it can range from that to as far as 1 hour, 15 minutes. So it's a typical because they are individualized sessions. And because of that nature, to be able to do this, it takes strength, it takes energy, and for one to do them. So, and if one did not do them in a structured way, one will not be able to see the impact of what one is looking out for. So, yes, the sessions are there, and this is just to give us a guide, something we can do, and with supervision, we'll be able to practice it effectively. So that as and we should, and like and most of us here know too, that as we continue to interact with our client or patient, more issues keep coming up. At the first initial assessment, not everything comes up, but we have things to work with. But as we go on, more issues keep coming up, and we keep integrating them into those things that will be amenable to those therapeutic interventions that we're going to offer. I hope this is able to answer in a very brief way your question. And also with the first earlier question raised about the epigenetics, this come up as part of the talk during the conversation that took place. That yes, uh, there are issues that may come up, but it is for us to be able to understand that when there are life stressors, they can affect the epigenetic environment of the individual at the genetic level. But this does not lead to change in DNA, but it does shows that environment play a role in what happens to us, and those roles are there. It has been attributed that it might have caused some genetic, some mutations, some people. But from what we know, stressor is what do change those gene environment that may affect the functioning of the individual. But as we're able to help the individual to take over the control of the environment, be able to be more adaptive in the environment, those epigenetic process should be reversed too, since they don't primarily go and change the DNA structure. I don't know if I'm able to understand the question effectively and I'm able to answer it to give uh, what is expected from this talk. Thank you very much.
Yeah, thank you very much, Dr. Jola, for answering the two questions. The one about the genetic and then whether the therapy is structured. Thank you very much. Are there any other questions? Okay, there's a hand up. Is that an old hand or another person has comments to make? Uh,
Good morning, Prof. I think it's my hand.
all right. Thank you. Please continue.
Okay. Thank you very much, Dr. Abiola. I'm so sorry. I was trying to chat, but I didn't see the sign. I'm getting used to this particular mode of virtual teachings, useful
You're
teachings.
more, you're more
Anyway,
used to it.
anyway, Dr. Abiola, so I wanted to know, is it advisable for you to um do two or three therapy at the same time? Hello, can you hear me?
Yes, I'm sure here.
Hello.
Yeah,
Yes,
thank
if
Yes,
assuming
yes,
you
yes,
have
I can
like
hear you.
your case, like that case summary you gave to us that you had the psychoanalytical um therapy, you have the CBT, you have the person center. Is it possible to use two or three at one session? Like you're seeing the person and you're like, okay, you do CBT and then you do the next one. Is it possible or is it advisable to, okay, this session we're just going to do CBT. Then maybe for the next one, we are now going to do psychodynamic therapy, something like that. Is it advisable?
If I understand your question, is that uh, the question
Mm,
is it doing supportive psychotherapy or doing those others modality? Because if it's doing those other modality, then they are not supportive psychotherapy. Because doing psychoanalysis, the jungle analysis, doing the cognitive
mm,
behavioral therapy, doing interpersonal psychotherapy. So all those ones are specific therapy in their own right. So they are not the same as supportive psychotherapy. So, but what supportive psychotherapy try to
okay.
do is that because it doesn't have its own theoretical foundation, but it picks from all this existing theory to be able to help people or individuals that need such help. And often these are usually like the first set of help, psychological help that people might have, apart from psychoeducation, might be the first sort of psychological intervention people might have, because the availability of this other depth psychotherapy are not easy, are not readily available. And because many people might claim I'm this, but it is the in the testing of whatever that what do you call it, testing of the pudding, and that you know what it is. So, sir,
The test of the pudding is by eating it. You know what
yes,
the
sir.
test
By
by.
the eating.
Yeah, by the eating. So, and what supportive psychotherapy try to do is that by doing your formulation, you already identify those issues, those problems, those challenges, those sufferings that the patient have psychology that you know you are going to work with. And so you're working with it. It's not one modality that will help you to do that working. Some other modalities will contribute to that. And that is why you are borrowing from them. But because we also don't have that depth approach to be able to help the patient with, that's why we can just pick those superficial that we know and be able to incorporate into this. But don't forget that the techniques in supportive psychotherapy are there and they have been listed. They are not like I'm bringing cognitive restructuring. No, I'm doing a thought reframing. So it's different from cognitive restructuring. It's not like I'm going to do uh, free association. No, that's not what supportive psychotherapy is going to do. Supportive psychotherapy will rather use that understanding of what is there in the past and try to bring it to the present and help the individual to see what he can do about it. Maybe by giving an advice for the person, he might be able to ameliorate it. And that's why those techniques are usually those tools that one will use to be able to change. It's just like has been understood. If you don't know what the psychopathology look like in cognitive therapy, then you cannot do the therapy. You don't have what to change, because if you cannot identify what is constituting those automatic negative thoughts, those cognitive error, you cannot pick what is uh, absolutistic thinking in the patient. We cannot pick uh, what do you call it, all or none. That's absolutely all or none thinking. Once we can pick those things and we're interacting with the patient, then I say we want to do cognitive restructuring, we want to do cognitive therapy. There's nothing we are medal, because it is until we find those cognitive errors and we ourselves have the skills to pick them. Those are the things we can use now, the techniques to address. So, but in supportive psychotherapy, that's why what is so obvious, that's what he asks us to do. This person is having relationship problem. We can pick it. We notice, because when we do our formulation, we can easily pick this person is feeling bad for losing his parent. We can pick it. This person is going through stress. These are things we can easily pick. And that's why he knows that once we pick them, do we just leave them and say, okay, just go and take only medication, which at times some people might not respond effectively because they don't know the medication is empowering them. What they need to do with the power, supportive psychotherapy can take them through that. And through those advice you might give, through the normalization that you are not the only person that might have experienced it and people recover, you can recover, through rehearsing and practicing the coping strategies in sessions, the patient start learning more and is able to do this and say, okay, now I'm going to get to it. So the mixing up of all those therapeutic modality is not as a result that one is going to do them. It's just that one is borrowing some obvious elements that is easier for one to be able to use at one's level of understanding and knowledge and be able to help the patient. But one don't have those depth understanding of what those theories are talking about, and so we cannot apply it to help the patient. I don't know if this address the question that you have in mind, or if you can reframe it. Thank you very much.
Thank you very much, Dr. Bruno. I understand.
Does Abiola ask whether has he made you or you asked a question? It's been answered. I hope to.
Yes, it has perfectly. Thank you, sir.
Uh, yeah, though I didn't ask the question, I think what Abiola says that most of the psychotherapeutic interventions have different menus in them. Analysis, for example, there are lots of sensory association, objection, catharsis, all those things that are there. Okay, but if you're doing some simple supportive psychotherapy, even if you're doing supportive psychotherapy, the fact that you borrowed a particular thing from psychoanalysis doesn't mean you are doing psychoanalysis. You just borrowed something, an element of psychoanalysis, which is helping you quickly resolve an situation. I think that's the conflict. You borrowed something. That doesn't mean that's what you're doing. You borrowed something to achieve the CBT and to help someone. It doesn't mean you are really going through the straight menu of you just pick a bit of it. Can one pick from many menus to help a patient with supportive psychotherapy? The answer is yes, one can. I hope that's what Abiola said. I'm trying to summarize. All right. Is there any other question? Now, I'm not asking the baby to ask questions. Asking the adults in the global, those who are carrying babies to mute themselves. Please,
Sorry, sir, there's a question in the chat box.
yeah, Dr. Abiola, can you see the question that has been dropped in the chat box,
Okay,
please?
yes. You see, please, what is the difference between supportive psychotherapy and psychoeducation in implementation?
I was trying to answer that question myself. Thank God someone person has asked it. All right, Dr. Abiola, your floor.
Thank you very much, the person that asked the question. Thank you very much, Prof. Like we all agreed last week, psychoeducation is different from health education in terms of the focus, because it picks each disease condition, it provides depth information about them, and it hopes that the person doing it will serve as a guide to help the person who is suffering from that illness to be able to have an understanding, engage, and appreciate why the treatment modality is this and why compliance is needed and the consequences of not complying, why it can do that for both patient and carer. Psychoeducation does that. Health education, like we did talk about briefly, is to enlighten people. It's so general, very broad, and it doesn't look at this. While psychoeducation provides what it does not in itself constitute a therapeutic modality. I mean, a psychotherapeutic modality. Let me clarify that. Psychoeducation does not constitute a psychotherapeutic modality because in that way is what is focusing upon is to be able to change attitude, to be able to reduce the pathway to receiving care, to be able to change the misinformation about the supernatural origin of mental illness, some of them which we know they don't have those supernatural origin, to be able to change that so that people can adapt themselves and be able to use what works and so that they get to it. Supportive psychotherapy is providing an intervention that is treatment oriented. That's one of his goals. And what he's trying to do is that to provide the psychotherapy, at least in the most basic form, to be able to help the people so that it can improve their self-esteem, it can improve their well-being, it can increase their coping skill. Why psychoeducation does contribute to improving coping skill, it might not contribute to self-esteem. It might not so. It's not providing way to reduce symptoms. It's just telling you that you need to do this to reduce symptoms. Let me create a scenario. Maybe somebody with bipolar affective disorder presented to the clinic and the individual have not been complying. And we look, why is this person having relapse? So we need to do something to help the individual to understand why compliance is needed. So, and psychoeducation will help to the individual to navigate that understanding so that the individual will know the treatment I'm being given is effective and I need to adhere to it. I need to, if I have challenges, this is what I need to do. That's what psychoeducation, in essence, is trying to do to educate the person or the family so that that empowerment will help them to manage and apply the therapy that is being given to the person. But supportive psychotherapy is offering a therapy. So psychoeducation will educate the individual to be able to use, for instance, supportive psychotherapy or medication and other form of therapy that is. So psychoeducation is doing this as a form of talking intervention. But as a psychotherapy, supportive psychotherapy is doing the one of the most basic function of all form of psychotherapy. That's why some experts even believe about more than 50% of any form of psychotherapy, you have to adapt and utilize those techniques that are present in supportive psychotherapy. But for you to be able to know up to 50% of what of the things that take another therapy, which means you must be an advanced practitioner of supportive psychotherapy. So that way you'll be able to utilize it well. So this is the nuance I'm trying to bring forward so that we can be able to appreciate that supportive psychotherapy is going to improve emotional functioning, emotional wellness, provide the individual with the resources, the psychological resources the person needs to deal with the extra psychic challenges. While psychoeducation is trying to see how to change the attitude of the people towards the mental illness so that the supernatural origin, which is widespread, will not keep hindering the progress made in towards the recovery of this patient. I hope this is I'm able to with my ranting. I don't know if I'm able to pass this message. Thank you very much.
And any other questions in the group or anywhere else?
So if I may add, if you remember, part of the comments to last week's lecture is from Professor Eri, where he said that the informational model of psychoeducation that is something for us to focus upon, because primarily that is what psychoeducation is doing, is providing information. Whilst supportive psychotherapy is providing treatment. Information do change attitude. And so the information are based on evidence that exists, scientific evidence that exists. That's what the information is based upon. But this is the other is giving treatment for help the individual to get well from the suffering. I don't. I hope this is able to link it together from some of the comments that was made uh, last week discussion. Thank you very much. Thank you, Prof. Sir.
Yeah. Any other comments or stuff written down that we want to look at? Yeah, maybe I should make another comment because it seems we are going to go through this every time. When I was a resident, the, we were the way we were taught psychotherapy was a bit different. We were told that there are two schools: the psychoanalytic, not psychoanalytical. Maybe when there's a change in behavior, when there's a change in mental state or change in behavior, there are two methods of dealing with it. Some people, I think it was what we call black box, right? Something that the mind is a black box and they don't go into it. That if someone is, say, bedwetting, for example, you don't need to go into the mind to check why he's bedwetting. There are things you should do to stop him from bedwetting. You reinforce the dry days, get something to wake him up each time he's about to pee. That way, you solve the problem. They call that behavior modification.
Other people say, no, that if there's a problem beyond maybe bedwetting, you need to go in, find out where the person was fixated as a child, and try to rewrite stuff in the person. But later on, we found out from teachers and things that the definition for psychotherapy is a bit different. That it is not what you do that makes something psychotherapy, but what you're making use of. Let me put it the other way around. That psychotherapy is any intervention where the therapist, client, or patient relationship is important in resolving or bringing a help or cure to the person. If we can get that. So whatever you do, sometimes we were told, I think in one of our last lectures, that I can't remember who was giving us the commonalities between different types of therapies. The most important thing may be the therapist himself. The name of the therapy is good, but far more important than the name is your skills and what you are doing. And whenever what you are doing, how you relate with the patients, how you relate with your clients, whatever you want to choose to call, when that becomes a fundamental thing in effecting changes, positive changes in the patient you are doing psychotherapy, it's not the name, it's not the process. I think if we have that in the back of our mind, let's take drugs for managing depression. Many of us who are psychiatrists are familiar with that. At the end of the day, one drug may not necessarily be better than the other, but you choose one over the other, not because of the effectiveness of relieving depression, but because of the side effects of the drugs. Someone is not sleeping well, you choose some medication that will make him sleep. Someone has lost weight, you choose something that makes him put on weight. All of them are the same thing at the final analysis. You choose drugs that are available. There are many good antidepressants used because they are not available. There are some that the restrictions of them make it difficult to use, more like the psychotropic drugs that you have to monitor. There are such things. So the psychotherapeutic methods are there. You have skill, the different peculiarities of the patient make you choose one over the other. And like Abela said in the supportive psychotherapy, sometimes you choose one or two aspects of one therapy and make use of to effect the change that you want in your patient. I don't know. That's for me how we should look at it. And in this lecture series, at the time, it's not lecture series, in the whole program, I mentioned last time that it's not a 1 year program we are into. It's going to be 1 or 2 or 3, depending on how we come and how we're individually making progress. We're going to get you exposed to all the, let's call this psychotherapeutic interventions possible. You have your own preferences, yes. The patients you have, they come with its own peculiarities, forcing you to leave one psychotherapeutic intervention and make use of another. So we insist that we all have the same working knowledge in several of them. So when you meet a patient, you can pick and choose. We also insist that you get enough advanced level information on about 2 or 3 of them. And you must decide on which of these therapeutic interventions you are going to specialize in. You understand that? So once in a while, what you prefer, what you have the styles to do, what you prefer may not be what is required by the patient. Its own peculiarities would make you choose something else. I hope I'm communicating. So the names are important, but more important, you remember the lecture we had, it's not the name that is the most important thing in effecting cure. It is the patient, the therapist, his skills, and the quality of interaction with the patient. So I think that's what I want us to. So let's not fight over whether something is psychoeducation or psychotherapy or CBT or behavior modification and all that. You will master, you would know all, have a working knowledge of each. You'll be able to do 2 or 3. You specialize in one by the time you finish. That's the preaching for today. Gentlemen, and let's see the time. Yeah, we've done that, except there's another pressing question or comments? Otherwise, we'll do the announcements and get ready for the next set of lectures we have to do. Are there any other questions or comments? Dr. Abiola? Are you see? Is there any on the chat group, please?
No, there's no more comments on the chat.
All right. Is there any hand up?
No, none, sir.
All right. So we'll do some announcements. Some of us are doing some programs, and next week Saturday may be an important day. I mean, for those of our brothers and sisters who are doing that the Christian fast or the Muslim one. Once in a while, we get lucky in Nigeria that it coincides for almost all the major states in the country. So one or two people have wondered whether we should lay off, that is, be off session next Saturday because of those religious observance. I think that would be a good idea. So next week would be off for next week. That is, the session would not hold like we've been doing. But there'll be lots of forms to fill and things. So before the week runs out, we have some forms everybody's going to fill. Part of the things we're going to add to the forms will be what's your area of specialty, your intended, what you prefer, so that we have an idea what you want to. Whether we've given lectures on it or not, it doesn't really matter. Write what your main focus, your interest of specialty would be. Then you also make a note on two other skills you want to grab as the sessions go on. That way it would help us plan a little bit better. That's number one. Number two. Number three is it's good to come and give lecture and go away. We are going to have groups, and the groups will discuss intra-group so that everybody in the group, that's more, we'll discuss it with, well, it's called a jigsaw kind of training program. We'll talk about the details as we go on. So we'll have groups and we'll have people in the same groups discuss among themselves so that the score for that will be the score of the group. So if you are a superstar, you score 100, the next person in your group is scoring 12. You know your score is not going to be 100, it's going to be something like 30 something. Because 100 plus 12 divided by 2 will be like 20 something or 30 something. So we're going to have groups. And the group members are expected to meet among themselves eventually, sadly, and master the concept so that at the end of the day, we would see how much information has been passed and how much information has been gotten. More importantly, how much information has been retained. So these are the things we are going to do for the next 14 days. So that by the time we meet after next week, I hope there's no holiday after that. I know there'll be another set of holidays around April or something like that. So we'll have lots of holidays in the next 6 weeks or so. So we'll be able to see which days are free and meet, and then when we get the groups functioning, the groups will meet also among themselves so that we can be sure that we are brothers keepers and we are holding and keeping people together who are in the same groups. I don't know if I'm making sense or if I'm being heard, because last week when I was talking and discovered I was talking to myself. I don't know. I'm not being
Yes, sir. We
okay.
understood you. We can hear you, sir.
Okay.
Thank you, sir.
We are listening. Yeah. Is there any announcement you want to add, Tajudi?
No, sir. No, sir.
All right. So, gentlemen, and Dr. Biola, I think we should, anyway, we'll talk about that so that during this 10-day, 2 weeks break we have, we'll get people all addressed with how far they've gone, and then we know what to do so that when we come back, we'll be better organized logistically so that we know who is in the program and who is not in the program. So, gentlemen, until 2 weeks from now, but the chat group is there and will continue activities in the chat group. So thank you very much. And thank you again for a beautiful presentation.
Thank you very much.
Thank you.
Very
All
good.
right.
Thank you very much, sir. Thank you very much, sir.
Yeah.